primary care setting, basically treating depression in patients who are HIV positive through our HIV Ryan White funded clinic, and how we're able to kind of focus in on this barrier. As we know, we've talked about many times, is depression can be a big barrier for compliance with HIV medications or compliance with appointments, and then gets in the way of getting a patient to undetectable or them being virally suppressed. So that's why we felt like this project was important. And we actually implemented this project. It's coming up on 3 years. We're on the 3rd year of our project. So we've learned a lot from it. And so we were hoping to be able to share a little bit of our project and a little bit of our experiences. So I'll turn it over to Tanya.
Thank you, Dr. Ladd. Can everybody hear me? Okay, so I'm here to talk about collaborative care. Like Dr. Ladd said, it's been almost 3 years since it was implemented here at the clinic. I am new to the program since August. First, next slide, please. But collaborative care is a way to integrate behavioral health care and primary care into one setting. So, and this is important because mental health problems can be a barrier to HIV care and compliance. And here at the clinic, the mental health treatment is provided by me. I'll develop a treatment plan with the patient and use evidence-based practices like cognitive behavioral therapy. Collaborative care with the patient usually lasts, between 6 to 12 months, and includes, 1 to 2 contacts a month between me and the patient. And what happens also is there's a psychiatric consultation that allows for the physician to have guidance on treatment for the depression. The contact is made by me to the therapist for a case review, and then the psychiatrist can make recommendations on treatment options. Next slide, please. So patients are identified using the PHQ-9 or the Patient Health Questionnaire. When they're here in the clinic, the front desk will give them that PHQ-9 for the patient to complete, and then the patient will give it to the nurse. So if the score is 6, which indicates mild depression or higher, the physician will refer the patient to me for collaborative care. And then if medication is determined to be necessary, the physician will prescribe the medication or request psychiatric consultation. When I meet with the patient for the first time, I'll discuss the collaborative care program and obtain patient consent, and then schedule a follow-up appointment. Patients with other mental illnesses or severe problems are not eligible for collaborative care. They would usually be referred to a psychiatrist. Next slide.
And so I just wanted to add in to the kind of what our system was like before we implemented collaborative care. Is many times if patients were experiencing depression or had a diagnosis of bipolar disorder or other mental illnesses, many times we would question the patient about and usually go ahead and refer them to our psychiatrist that's contracted with our clinic. And then we also had a therapist that was available if they needed for counseling. When we implemented collaborative care, what changed was that we took the treatment into our own hands. Like, we still have the psychiatrist here if we needed to ask questions about, what would be optimal therapy or, those types of things. But we could then say, okay, this patient has depression. I think I can treat this patient's depression. I'm going to start them on this medication. And then also set up the counseling at the same time. As we know, many times the two go hand in hand, using medication as well as using therapy sessions in conjunction with each other to help the patient and improve symptoms. And in some of those cases, we may find, okay, maybe they don't need medication right now, but they're going through something through life that maybe they need to talk to somebody about, but maybe they don't necessarily have a chemical imbalance and maybe they don't need the medications. And so collaborative care was a way to keep them still in primary care where we could treat them if they needed medications or just treat them with counseling through therapy if we needed to do that, and be able to still take care of their problems without having to refer them out to a psychiatrist or any of those things. So it was just another way that we could do that without having to refer to the psychiatrist, but still be able to utilize the psychiatrist for kind of like a curbside if we needed some help in terms of the medication. But what we didn't do is we didn't do it for things like schizophrenia or maybe even bipolar disorder and other things where they may need the psychiatric referral and consultation. We were primarily doing collaborative care for depression.
Yeah, and I think that makes it easier for the patient. So
absolutely.
Yeah. So COVID-19 has brought some challenges. More patients are being seen virtually. So, they're not here to fill out that questionnaire. So during the rooming process, the nurse will ask those questions to get that PHQ-9 completed. And then if necessary, they'll make a referral to me and then I'll contact the patient by phone to speak with them. And also, since some patients are not comfortable coming into the office, I am able to do visits virtually or over the phone. So that way they don't have to come into the clinic for an appointment. Next slide, please. So the benefits of collaborative care is that it makes it easier on the patient because they're able to receive their medical care and mental health care at one location. Appointments are also reduced for the patient, which makes it easier since they are able to see the primary care physician for their prescriptions instead of having a separate appointment with the psychiatrist. It can also reduce costs for the patient because they have fewer appointments. We do monitor the PHQ-9 score for improvement. And then, of course, when the patient's depression symptoms improve, their treatment compliance improves. So they're more likely to come in for their appointments, stay on their medication, and come in. So next slide, please. So the future, we are going to be expanding this program next year. Right now, it's just on a grant funding that only allows for African American and Hispanic MSM men to be eligible. But next year we will expand that to include all patients, and then there will be an additional therapist available to do collaborative care, and that's Lisa Harrison, who's already here at our clinic as well. So, so that way we can meet the needs of our patients and provide services that they need. Any questions?
Thank you, Tanya. That was excellent. We've seen lots of changes with